The following podcast is part of a certified educational activity titled Fine-Tuning the Wave of Innovation in RCC, Personalized Management Across the Disease Spectrum. Access the entire activity and complete the post-test at peerview.com/DGX860. Downloadable slides and practice aids are also available.
All right, welcome everybody. Thanks so much for coming out on this first day of ASCO. It's wonderful to see everyone here. We've got a fantastic evening planned for you tonight. We're going to be discussing new innovations in renal cell carcinoma with a really terrific faculty that I'll introduce in a moment. We're actually going to focus a little less on the didactic. I'm really going to try to spice it up with a lot of interesting case discussions to keep everybody here on their toes. And we've got a terrific, phenomenal panel that we'll go through in just a moment here. My name is Monty Palin. I'm a medical oncologist at City of Hope in Los Angeles. And our goals today are to really augment your understanding of the knowledge of the efficacy and safety of approved agents for renal cell carcinoma. We're really going to talk about personalizing therapies across various clinical scenarios and give you some guidance in terms of how to mitigate side effects. Now, we really want to thank KC Cure, our partner in all of this, Dina Battle, who is really the origin of KC Cure, is here in the audience today. And they've done a tremendous job in terms of really reflecting the patient voice and a lot of the work that they've done over the years. You're going to see some of the patient-centered research that they've done peppered through our presentations with a lot of the clinical trial data. And I think that's really important as we try to contextualize these therapies. Now, first, I'm going to introduce a dear friend and colleague of mine, Dr. Pedro Barada. He's the director of GU Medical Oncology at Case Western. We've all followed his career with a lot of really sort of serious intent. He's a rising star in the field, and he's going to be discussing perioperative options in renal cell. Pedro?
So Monty, really, pleasure. Thank you for the invitation. Thank you guys so much for being here with us and decide to spend the evening at ASCO, right? Really busy for everybody, and including seeing a lot of friends and colleagues in the audience as well. So let's get things started. I'm going to try and fly through the slides so we have fun time during the discussion. Let's start with localized, non-metastatic RCC, right? So we know that we have a lot of success stories with systemic therapies in the perioperative setting for a lot of solid tumors, but for whatever reason, that doesn't seem to be quite the case yet. At least specifically think about neoadjuvant. The data kind of seems to be lacking still to support use of neoadjuvant approaches for kidney cancer. We know that surgery is the gold standard. We can cure people. Unfortunately, the risk of recurrence for patients, specifically stage 2, stage 3, it's not insignificant, right? It can go between, sometimes to 20 to 40%, sometimes even higher, for patients who end up getting post-surgery a recurrence at any point in time. So currently, we do not have approved, neoadjuvant or preoperative systemic therapies available. That is true that sometimes in clinical practice, we have some discussions on a case-by-case basis, but not as a standardized approach. And, and the standard of care right now for patients who underwent surgery is to discuss TKI and as well as immunotherapy. And I think I'll go through that data. So again, think of neoadjuvant just to remind us where we are, not standard of care. It can be yet and still be used in selected cases, and we discuss all the time in our tumor boards. There's a number of different target therapies, particularly angiogenic therapies, being explored. They've been explored in that space, right? And however, responses are relatively modest. We have a little bit more responses in the clear cell subtypes, perhaps up to 20%. If we were to summarize grosso modo, the efficacy in the clear cell RCC, and that number seems to be even lower for beyond clear cell histologies, non-clear cell subtypes. However, there's some promising or interesting data emerging, and I think we are influenced by what's going on in the advanced setting. So we're testing IO-based approaches in the neoadjuvant setting, an opportunity to highlight the data, for example, with axitinib and avelumab, the NeoFX, that basically, reveal reports of around 30% of tumor shrinkage in the kidney, and it doesn't seem like we lose the opportunity for cure in those individuals by offering a neoadjuvant approach. And there's a number of other studies that are currently recruiting, so it'll be interesting to see what happens with those. So what is important to set up, and changing gears to the adjuvant setting, patients who received surgery or nephrectomy, partial or radical nephrectomy, and there's always a balance, right, about what we have to do, right? And the balance is between what is the benefit? Can I cure patients? Can I prevent them for coming back, months or years later with progressive or recurrent disease? And, as in exchange for some potential toxicity and some inconvenience and some financial toxicity associated to whatever we decide to do in that adjuvant space. So I think that balance is always present, and we try to figure it out what is the right balance for the patient we have in front of us. And of course, we have always that in mind when we're thinking of sunitinib, or we think about pembrolizumab, or we think about, maybe not doing any of that. And so, of course, we'll talk about that in the next few slides. So just to say that in clinic, a lot of us actually sit down and look at the patient in front of us. We look at the histology. We look at some characteristics like tumor size, for example, and we can use some scores that are really handy and can actually help us to determine, or at least to predict, risk of recurrence. And that number, that score, although patients are not numbers, right? But that score at times can help us make a decision about a role of adjuvant therapy or a yes or no kind of thing, right? So this is an example of some scores that can be utilized in clinical practice. So as I mentioned, there were a number of clinical studies investigated different TKIs, older, newer TKIs, but you see there's a common theme, right? There are heterogeneous populations in all these studies. There's one study, only one, that has met the primary endpoint for disease-free survival. All the other studies have been negative, right? And I think that's relevant because actually that study, the ASTRAC, led to the approval by the regulatory agents for sunitinib a year, in those patients. But all the other cases, we failed to demonstrate the benefit. Including the ASTRAC trial, we actually end up not seeing a survival advantage with that approach. We did see prolongation of time to more disease in the scans. One other line, because this trial is relatively recent, or is perhaps the most recent study with regards to target therapy beyond angiogenic drug. This is an mTOR inhibitor, everolimus, was tested in the adjuvant setting, phase 3 trial Everest. It was actually, I have to say, kudos. It was a big cooperative group effort. There was a lot of effort put into this study. And although it was a negative study, I would argue that actually a lot of us did not expect this near miss, if you will, as you can see, at least statistically speaking, right? With an hazard ratio of 0.85 for recurrence-free survival, and barely or almost meeting the pre-specified p-value to meet criteria. Anyway, it's a negative study. We're not doing it in clinical practice, but I think it's relevant to be thorough, just to make sure we cover all the target therapies to be investigated in this space. Now, what we really want to talk today a little bit is about immunotherapy, right? So we tested angiogenic therapies, we tested mTOR, and what about immune checkpoint inhibitors? And we have a number of studies. I think some of these are very familiar to the audience here. I'll start with PROSPER. PROSPER is another effort from the cooperative group. It started as a really perioperative design. We were doing 3 doses of nivo pre-surgery, followed by the rest of it as adjuvant setting. And then we amended the protocol to do 1 nivo pre-surgery, followed by 9 doses of nivolumab afterwards, compared to observation. And designed amended, or the updated design is in this slide. And the safety committee ended up stopping this study at the interim analysis because we didn't see a benefit. So the first of the studies with checkpoint inhibitors that I'm going to show you tonight, unfortunately, did not meet the primary endpoint. In other words, it did not help patients who were enrolled in this trial. And then we had Emotion 10, which is a relatively different, more like bread and butter adjuvant study, meaning patients who underwent surgery and had intermediate to high risk disease end up being randomized to atezo, up to a year, or placebo. Again, endpoint for all these trials is disease-free survival, and this trial was again negative, and so it was I won't say shocking, but at least it did not pan out, or it didn't prove to us that actually adjuvant PD-L1 inhibitor was helpful. And then we saw also recently the data from CheckMate 914. In reality, CheckMate 914 has 2 cohorts, Here I'm showing you the cohort A, or the part A, I should say, with ipi-nivo. In this case, it was 6 months of ipi-nivo compared to placebo. Very similar patient population where we were taking, PT2As with nuclear grade 3s or 4s and or above, so N positive disease or PT3s, PT4s. And we saw this data when a median follow-up of over 3 years, a little bit over 3 years. The trial was also negative, or at least the part A of this study was negative. We're getting an update at ASCO regarding subgroup analysis by Dr. Moser and the group. But bottom line is, they gave us a lot of pause, right, about the role of different checkpoint inhibitors, in this case, a CTLA-4 inhibitor with a PD-1 inhibitor. And finally, we leave the best for last, or at least the positive trial in this setting, the Keynote 564. Of course, we had great work from Dr. Choueiri and the team here, presenting this data. A very similar design to the Atezo adjuvant study, in a sense that it's a post-surgery. You're considering patients who have a higher risk for recurrence. So you actually took the intermediate high risk, and post-metastasectomy. So PT2s, grade 4s, sarcomatoid, and then PT3s, P4s, and positive disease. And they were randomized to standard year of pembro versus placebo. And disease-free survival was the primary endpoint. I think at this point, a lot of us are aware of the data. This is a very important paper, New England, a practice change, in my opinion, based on the data you're seeing. This is the primary endpoint, disease-free survival. At the first analysis of around 2 years, 24 months of follow-up, you'll see there's grosso modo about 11% or so absolute difference in disease-free survival at 2 years, or in other words, 77% disease-free compared to 68% there. And then you have a follow-up, an updated follow-up, where you continue to see that difference, of a similar delta. What I think I would highlight here is actually the hazard ratio actually goes down. So there's a 32% risk reduction at 2 years that turns out to be 37% over time. And I think that speaks, about the positivity of this study. It seems to be persistent, with longer follow-up, which is, in my opinion, is relevant to see. Another aspect that I think is relevant is the breakdown. Again, remember, the study was not powered to answer the question for specific groups, intermediate high risk, and post-metastasectomy. But I do think it's important to see that, it's basically you have a benefit seen of 32%, of 40%, and then 72% as you walk from, or as you move from the left to the right side of the slide, suggesting that potentially patients who are at a higher risk for recurrence, when you start asking the question, is not really if they recur, but when they recur, that the benefit seems to be even more obvious or evident based on this data. Again, cautioned, the study was not designed to find those differences, but yet I think is relevant clinically to see how the numbers behave here. And the other aspect of it, I have to say that OS is immature as we're speaking, right? Overall survival data is immature. However, I do believe it's also relevant to note that at 2 years, we see a difference of a risk reduction for death of 46%. Actually, the hazard ratio drops to 0.52, meaning the risk reduction is actually greater, 48%. At a 30-month follow-up. And that kind of seems to be, it seems like patients not only are delaying time to progression, but maybe we're able to talking about cure with the addition of 1 year of pembrolizumab in the adjuvant setting. So as we move forward, how can we build on that? So after the approval of pembrolizumab for patients at a higher risk for recurrence, this trial that I'd like to highlight, LightSpark 22, it's building upon the success of Keynote 564, and is actually asking the question whether or not the addition of belzutifan, which is a HIF inhibitor approved for germline VHL, and Dr. Choueiri will tell us all about it later tonight, and is building upon the pembro as monotherapies. As you can see there, pembro is in both arms, and you add belzutifan to pembrolizumab in the investigational arm. Disease-free survival is a primary endpoint, and they're looking for 1,600 patients in this trial, and this trial is open for accrual. And so I think I'm very excited to to see when the accrual is completed and we see what the results are for this particular study. Again, going back to the question where we started, right? The balance is so critical. And I do believe when we look at FDA-approved therapies, pembrolizumab on one end, sunitinib on the other end, these are very different therapies, right? With a very different safety profiles, right? And we have to think that in favor of immunotherapy, of course, significant toxicities are much lower, right? There's a question that possibly it might extend overall survival. The data seems to be promising, is immature. We got to wait and see. But that's what we have thus far, hazard ratio going down over time, and that's of course a confirmation of at least preventing disease recurrence at the 2 and 3 month, 30 months of follow-up. Excuse me. But then you can of course think about, there's always the concern regarding immune-mediated adverse events being significant or life-threatening in some situations. There's also the financial toxicity. What's the financial burden to patients, and of course the inconvenience, right? We're doing treatments every 3 weeks, although we can, we have the approval to be able to do this every 6 weeks, which is perhaps more convenient, but the study investigated in a 3-week regimen. So nonetheless, there are definitely differences, between immunotherapy and sunitinib, but it's my sense, from talking to community colleagues that, the adoption of immunotherapy has been real, which has not really been the case for angiogenic sunitinib. I will really highlight, not because Casey Cure is helping us putting this meeting together, but also because they're doing actually fantastic and I should say pioneer work in the kidney cancer arena, because they're actually getting data directly from patients. And it's quite striking to me, at least, to see how they can come up with hundreds and thousands of patients' data and put it in a form of, important papers like this paper, from Dana, Dr. Bergera, Monty, and others, and I think the message that it comes out of this data is really, really relevant. So you can see the emotional well-being, and times these diagnoses change, as you see, particularly on the left. So it seems like patients get a lower rate of distress as time goes by and they remain without recurrence. However, when you look at the fear of cancer recurrence, that remains high over time, and that doesn't seem to drop. So I think that it's an important message as we counsel patients, as we talk to them, as we go through, as we see them visits after visits with restaging scans. I think this is very meaningful information to have. And the other piece, of the data, again, from Dana and Casey Cure and the group, look at that, over 1,000 patients, participants in this particular study here. Actually, we have, I believe, is in a poster form at this meeting. So, it's the largest meeting. You can get this data out there. You can see, which is to me is quite interesting, and it shows how different is the message, right? One thing is what the provider communicates with the patient, and the other thing is how is the patient taking that message. And that can be many different things, right? And so as you can see, for different stages, the question was the perception, the perception of how likely are you to recur, right? And you can see at blue, you have the patient perception, and purple, you have the physician perception. And so basically, patients do perceive their recurrence risk to be higher, I would argue significantly higher, than actually physicians for a respective stage where patients are. And I think that's really an important message, because we are dealing with patients who happen to be dealing with kidney cancer. We're not dealing with kidney cancer. So that is important, and so kudos to Casey Cure for getting this data together and showing it to the world. So with that, I'll pass the baton back to Monty, and I'm looking forward to the discussion and the rest of the talks from my colleagues. Thank you.
Excellent job. Great presentation. You actually kept us right on time, which I really appreciate. So we've got lots of time for some case discussion here. So we're going to look at the case of Maria, who's a 7-year-old patient who presents with gross hematuria. She had the abdominal CT that you see here, which shows this 12-centimeter right-sided renal mass, and she underwent a right-sided radical nephrectomy. It was a 12.1-centimeter tumor at the time of resection. There was some distal renal vein involvement. You can see that it invaded into the perinephric fat with negative margins. It was grade 3 with clear cell histology. There was some rhabdoid and focal sarcomatoid differentiation, and the final staging with margins negative was T3A NXMX. She recovers well. In a scenario like this is a softball question, so let's see. I'm going to give it to Dr. Choueiri here. What would you recommend in this particular situation? Surveillance, pembrolizumab,
When do I
clinical
see
trial?
the patient? Is that 2018, 19, or today?
Let's say today. Let's say today, 2023.
Yeah, so this is a patient at relatively, high risk of recurrence, not just the stage. I think here, the rhabdoid and the focal sarcomatoid differentiation are really important despite the post-surgical imaging, and I assume then the margins are negative. So this person I would discuss with adjuvant pembrolizumab. They have clear cell histology, they have everything. They could have met Keynote 564 criteria.
And what do you think in terms of eligibility for clinical trials? Would this sort of patient fit the bill for your trial?
They would fit the bill for the trial that Pedro presented, which is pembro plus minus HIF2 inhibitor. They are at relatively higher risk, intermediate grade, but also T3A, sarcomatoid features, the size plays a role. Of course, you can put all these, unfortunately, elements and a clinical and pathologic criteria kind of from the 90s and early 2000s. They haven't changed much. You can put them together into a nomogram and counsel the patient. I would say anywhere between 20 to 60%, depending on the nomogram that you pick. Unless Dr. Michael Stahler does the surgery, which guarantees 100% cure, I would have to offer the patient pembrolizumab probably.
Yeah, I think that makes sense. So let's say it was Tony's outstanding fellow, Dr. Salibi, that sees the patient. She goes through the imaging and she spots a lung nodule. Okay, and it looks totally resectable. Let's say it's a 1 centimeter nodule in the right upper lobe. The thoracic surgeons say we can easily cut this out, and they do. Christina, in that situation, you've got a patient who's had this 1 centimeter lung nodule resected. She has this high-risk localized tumor. How would your treatment change? Would you still offer adjuvant pembrolizumab in that scenario?
Yes, of course. I think that's the better benefit. That hazard ratio is 0.29. So I have no doubt with these patients that in the past we didn't know what to do. We sometimes were thinking like, should we treat these patients because they are metastatic, but we removed all the meds. So, and we had that trial with pazopanib that didn't demonstrate anything with the anti-angiogenics in the metastatic setting. But now with the pembrolizumab, I'm sure that I would offer I'm very convinced the adjuvant treatment.
So if you've been to these programs before, we know we make the scenario progressively more and more challenging as we go along. So let's say this was a patient who decided they didn't like Boston. I can't blame them. They decided to move out to the West Coast, to Los Angeles, and they came and saw me. And my fellow, Dr. Zengen, actually sees the patient and actually takes the pathology slides, downstairs and says, wait a minute. This is actually a papillary tumor, in fact.
So we read it wrong. The moral of the story, Boston doesn't know pathology.
So let's say this was a papillary kidney cancer instead. Pedro, what would you do in that scenario? So again, same scenario. Let's imagine high risk, localized. Let's just stick with localized here. In that particular scenario, if the histology was papillary, would you offer adjuvant therapy, and if so, what?
So no lung met, right?
No lung met.
Okay, because we wouldn't miss the spot in the lung if he was to see in Cleveland. So right now we don't have, in my opinion, solid data to support adjuvant therapy. So in non-clear cell histologies, we are not, outside a trial, we're not offering adjuvant therapy. So I would not offer him, adjuvant pembro in that situation. Yeah.
Okay, you would not, correct?
I would not. Yeah. In the absence of metastatic disease.
Yeah, Tony, what do you think?
I would actually suggest it, and I would say, I would suggest that I think the risk of recurrence is very high. The reason is, you have to have a discussion with the patient. So this will be kind of on-label because the approval was in kidney cancer, but a bit of academic discussion because Keynote 564 did not enroll patients with papillary renal cell cancer. So the only closed data here, and this is, comparing a bit red apples to green apples. So, I don't know, apples from Boston to apples from LA, is that we do have data in pembrolizumab in metastatic papillary RCC patient, untreated first line, and the response rate, is not like chromophobe, is around 30 to 40%. So, if the patient, it's not completely, out of context to provide it, knowing that, and that's where I may disagree a bit with Pedro, I will bet there will probably almost never be a study of Pembro or IO strictly in papillary RCC. This is a study that's impossible to recruit unless every center on earth open it. But it's a tough call because pembrolizumab, every systemic therapy, especially if this patient is cured by the beautiful hands of Dr. Taylor, then there is a toxicity.
Sounds like you've got a comment on that, Pedro.
No, I was thinking in that situation, if he had the lung spot, which I thought that was your question, then if he were to come to us, I probably would get systemic therapy up front. And then, yes, we would have. That's what I would have done, right?
Yeah.
Actually, I would do an IO TKI.
Yeah.
I would not. I agree with you, McDermott data, Pembro, but actually, I think we have even better data with IO TKI. Not just the Cabo from Monty, but also Cabo Nivo, for instance, right? We have Cabo Nivo and LenFPAM. I would actually do a treatment induction up front. So I use the SAGE-4 as an excuse, find me my good actors, and then perform a debulk nephrectomy at later time and maybe address the lung. But I would give him a trial of systemic therapy, and I would feel very comfortable doing that.
Interesting approach. What about Spain, where there is nothing approved?
You need to mention that.
Sorry.
Yeah, thank you. But we have apples. So yeah, in Spain we have no choice. So we wouldn't be able to give any adjuvant therapy to this patient. But anyway, if I could, I see Tony's point. But with no meds, it would be for me a little bit difficult to suggest the adjuvant treatment.
I'm kind of with you. I'm somewhere in between you guys. So let's say this patient ultimately decides to go back to Boston, right? They miss Tony, they miss Dr. Salibi out there. And let's say the pathology gets re-reviewed a second time, and now it's not papillary anymore, it's chromophobe. Okay, and this happens. We see localized chromophobe, right? And high-risk localized chromophobe. So in that scenario, Pedro, what would you do?
I mean, again, I'm a data-driven person. I would not consider, again, assuming there's no disease beyond the kidney, I would get a great surgeon to perform surgery and, fingers crossed.
Okay, I think that's totally fair. Now, this is a scenario that I see kind of coming up more and more. So let's take that patient. Dr. Sleepy's identified a 1 centimeter lung nodule. You've cut it out, okay, all right, and you, instead of that 1 centimeter lung nodule popping up at the same time as the nephrectomy, let's say that lung nodule popped up 3 years later. 3 years later, okay? So the patient had surgery in 2020 for their kidney. They had surgery for their lung in 2023. In that scenario, Christina, would you offer adjuvant Pembro?
Clear cell? Or?
Clear cell,
Yeah.
clear cell.
Yeah, I think so, but at the end, it's a systemic disease. So it's a different systemic disease than the one you have when you have a synchronous med, but at the end, it's systemic disease. So I think I would offer anyway.
So 3 years later, because in the trial they kind of stuck with that.
I see the point that it's not the 1 year of that, but yeah, why not?
What do you think, Pedro?
I would probably be lean towards making sure is 1 is not 2 or 3, because then my discussion would be what kind of systemic therapy I would offer, and instead of resecting, but oligomet, right, recurrence, a late recurrence, 3 years later, 1 spot, I would have that conversation about considering adjuvant Pembro for a patient with clear cell.
Okay, and you're our tiebreaker, Tony. So
3 years?
3 years. 3 years later.
I would not actually.
Okay. So are you pretty staunch in that sort of 1 year threshold?
Right,
or?
1 to 2, because the data we generated from the old times in Cleveland, and we have some Cleveland alumni here, shows that it's between 1 to 2 years. So we picked the 1 year because that's the highest risk of recurrence, but there is data within 2 years. I think more the risk becomes low. You can, in theory, do it because again, the approval, at least in the US, the blanket approval, make you do it. But I will take my chances after 2 years. Within 2 years, I'll do it, knowing that 1 to 2 years is outside Keynote 564. The new study, Pembro HIF2, allows up to 2 years.
Okay. Okay, fair enough.
But
So, I mean, it's a tough question, and I think there's sort of a gray zone. I've seen lots of different modes of practice in my area. I'm going to turn it over to Dr. Suarez, who's actually the senior researcher at Val Hebron and is doing just tremendous work in the field of kidney cancer. We've done a lot of studies together over the years, and I'm really excited you were able to come out for this program.
Thanks, Monty. So, I'm going to talk about first-line therapy. And as you all know, the better knowledge of the biology in RCC has dramatically changed the outcome of our patients. So in the past, before 2005, when we didn't know the anti-angiogenic pathway and the mTOR pathway, we were supposed to live in the dark age with the cytokines. Patients live around one year. With the arrival of targeted therapy, especially with anti-angiogenic treatment, we were supposed to enter into the modern age where patients live around 30 months, and we have some patients with long survivors. We are now living in the golden age where the IO combinations have replaced the monotherapy with TKI, and we will have around 50% of patients that will be long survivors, and our overall survival, median overall survival is around 5 years. And we aim to arrive to the diamond age where around 80% of our patients would be long survivors. So what are these different combinations? As you all know, we have two options, IO-IO or IO anti-VEGF. We are going to start by IO-IO. You all know the CheckMate 214 trial. The CheckMate 214 trial includes patients with metastatic or advanced clear cell carcinoma or component of clear cell component. They were stratified by IMDC and region, and patients were randomized to receive nivolumab plus ipilimumab for 4 doses and followed by nivolumab versus sunitinib. Here, the primary endpoints, and this is a difference with the rest of the trial, were PFS, OS, and overall response rate in the intermediate and poor risk patients. So this trial was positive for overall survival in the intermediate and poor risk patients. This is the last median follow-up with 5 year median follow-up of 5 years, and in the ITT population they had a very similar results. The favorable risk patients did not achieve this benefit with ipilimumab, nivolumab, and the same happened with PFS. This trial was positive for one of its primary endpoints, the PFS in intermediate and poor risk patients. Again, in the ITT population, similar results to the intermediate poor risk patients, but again, no benefit in the favorable risk patients. What about overall response rate? Overall response rate was higher with the combination. It was 42% in the intermediate poor risk patients and for Nivo, EP, and versus 27% with sunitinib. In the favorable risk patients, the response rate was higher with sunitinib, but a higher proportion of patients achieved complete responses with nivolumab plus ipilimumab versus sunitinib, regardless of the risk. So even in the favorable risk group, patients achieved more complete responses with the combination of nivolumab and ipilimumab. And what about the median duration of response? So median duration of response was notably longer with the combination in all 3 populations, and in fact, in the intermediate and poor risk patients, that was the primary endpoint, despite being the trial with the longest follow-up, the median duration of response has not been reached, and this is something important, and we will talk about later. And an improved long-term quality of life was also observed in this 5 years follow-up. So it's important to know that immune-related adverse events can occur at any time. But we know that usually the immune-related adverse events follow this pattern. There are some adverse events that occur at the very beginning, like skin adverse events. Colitis, pneumonitis, or liver toxicity usually occur in the middle of the treatment, and other adverse events like nephritis usually occur in patients that have been treated for a long time. Usually, all these adverse events will be resolved in a relatively short time, but there are one adverse event that is endocrinopathy that the patients will probably need to live all their lives with it, and this is important to know. So it's important to explain patients what they can what the things or symptoms they can have, and how to. It's important to identify these immune-related adverse events and to make patients understand what can happen, because patients will be more likely to adhere to treatment when they have a full picture of these immune-related adverse events. So, moving forward to the other option. So, as you all know, the other option we have is an IO combination with an anti-VEGF. All the trials have a very similar key eligibility criteria: newly diagnosed RCC with a clear cell component, no previous systemic therapy, were stratified by IMDC and geographic region. And patients in all these three trials that demonstrate overall survival had the same comparator, as you know, that was sunitinib, and the combination arm were pembrolizumab plus axitinib, nivolumab plus cabozantinib, or pembrolizumab plus lenvatinib. Starting with the Keynote 426 that compared pembrolizumab plus axitinib versus sunitinib, the primary endpoints, it had two co-primary endpoints that were PFS and overall survival in the ITT population, and this trial, as you all know, was positive for these two primary endpoints. And regarding, again, the overall response rate was 60% versus 40% with the combination versus sunitinib, and the complete response rate was 10% versus 3.5%. Quality of life outcomes were not different in this trial, and progression-free survival too. That is defined the time that the patient since the patient starts until he needs to start the following line of therapy or dies, or whichever occurs first, was longer for patients in the pembrolizumab plus axitinib group. We will have an update presented by Brian Riney of the 5-year analysis and follow-up. Moving to the CheckMate 9ER, as you know, that was nivolumab plus cabozantinib. The primary endpoint in this case was progression-free survival, and overall survival was a secondary endpoint. This trial was positive for both endpoints, and interestingly, in the last follow-up, nivolumab plus cabozantinib arm improved by 12 months since the previous data cut. So overall response rate again was higher in the combination, 55% versus 28%, with 12% of patients achieving complete responses. Median duration of response was 23 months, and patient reported outcomes maintain or improve along the time with nivolumab plus cabozantinib, especially in the delay of or time to deterioration. And regarding exploratory analysis, especially biomarkers, PFS benefit was independent of PD-L1 or MET status, and the select gene expression signature used in other trials didn't demonstrate any predictive value with nivolumab plus cabozantinib. And PD-L1 was prognostic in this trial, but was not predictive for the treatment. So PD-L1 should not drive clinical decisions. We knew we knew before this trial that overall response rate has a directly relationship with outcomes in RCC. We knew from the TKI era, we knew from ipilimumab, nivolumab, and we showed in this trial as well. So patients that achieve better responses had better outcomes in overall survival and PFS. This year will be presented tomorrow new data by David Sella regarding quality of life. And finally, the CLEAR trial, you know, that has a different design with 3 arms: pembrolizumab plus lenvatinib, lenvatinib plus everolimus, and sunitinib, but we are going to focus on the pembrolizumab plus lenvatinib arm. The primary endpoint here in this case was PFS, and again, OS was a secondary endpoint, but this was a positive trial for both endpoints. Overall response rate was really high, was 71%, with 17% of patients achieving complete responses. Median duration of response in this trial was 26 months. So in the CLEAR trial, the PFS benefit was seen across all the risk group, and a large proportion of patients, around 1/3 of patients, could complete the 2 years. And quality of life results demonstrated similar or favorable scores in patients in the lenvatinib plus pembrolizumab arm, especially respect with the time to definitive deterioration. So final analysis of OS will be presented as well on Monday, with an OS benefit. They maintained the OS benefit and the PFS benefit, and the overall response rate was greater, again, with lenvatinib pembrolizumab, with similar data that we have before. So what about next generation trials? So one of them we have already published by Tony, so if you have any questions, maybe you should ask him, the COSMIC 313 trial. And it was the first trial in first line that comparing a triplet, and the first with nivolumab, ipilimumab plus cabozantinib, and the first trial where the comparator arm is a doublet is nivolumab plus ipilimumab, and it was a positive trial that has been published last month in New England for its primary endpoint, that was progression-free survival with overall survival data immature. There are many trials trying different strategies, and other trials trying triplets like the umbrella trial, but I think that these two trials, it's important to mention the pedigree. I think Tony has something to say about the pedigree as well, and with a very, very smart design. And this is a trial with adaptive design, and starting with nivolumab plus ipilimumab, followed by nivolumab plus cabozantinib, depending on the response. Maybe Tony can explain with more detail. And the LIGHTSPARK-012 trial that is exploring belzutifan plus lenvatinib plus pembrolizumab, so another triplet. Sometimes coping with the adverse events from IO-TKI can be difficult, especially because some of them can overlap, like rash, diarrhea, hepatitis, or hypothyroidism. So maybe a good strategy is to hold the TKI, as it has a shorter half-life than the checkpoint inhibitors. So if symptoms resolve in a few days, TKI was likely the cause, and if the symptoms don't clear up, probably it's the IO causing these symptoms. So in summary, we have 4 trials that demonstrate overall survival in first line. They have comparable or similar results in hazard ratios in OS or PFS. Trials with TKI with a BGF containing regimen have higher overall response rate, but the only trial with IO-IO, the nivolumab ipilimumab trial, has the longest median duration of response, as is the only trial with the median duration of response has not been reached. And this is a very interesting work, and I really like this work. I really like work with patients. So this aims to understand the patient's point of view regarding adverse events and how we manage adverse events. So of this trial, for me, the interesting thing is that most of the patients didn't ask the doctor to reduce the dose of the TKI, and this is probably due because they were concerned, they were worried about like reducing efficacy if they reduce the dose. So I think it's very, very important to encourage the patients to report any adverse event right away, so we can manage adverse events in an early stage and induce or including adjustment of the dose, and this will allow patients to keep receiving an effective treatment as long as possible and maintaining the quality of life. And I think now Monty has a case for us.
Well done, Dr. Suarez. That was terrific. Thank you. And again, awesome job on timing, too. We've got lots and lots of time for some really tough questions. So we're going to start with a clinical scenario. So this is that same patient that we discussed previously who actually was resected and ultimately did quite well. After 24 months, imaging showed 3 enlarging lung nodules. And we're going to imagine a scenario here where she did not receive adjuvant therapy. Okay, so this was a couple years ago before the approvals came around. So after 24 months, she has these 3 enlarging lung nodules. Now she's classified here as being favorable risk. Her hemoglobin's 12, KPS is 90, neutrophils and platelets are normal. What treatment options would you favor? And before we get to that, we have this concept of favorable risk disease that we're discussing in the context of this patient. We have a great question from the audience here who asks, how often do you actually use that term favorable, intermediate, and poor when you discuss with patients? Maybe I'll start with you, Christina, since you gave us that lovely talk. Do you actually use that terminology as you're reflecting on patient conversations?
Sometimes, but usually, if they, I don't know, I explain more or less patients what are the classification, but sometimes it's, at least depending on the patient, it's difficult for them to understand what I'm meaning, and especially if he's going or she's going to be a poor risk patient, maybe he doesn't want to hear that. So I have a case like some months ago that they can't see their own history from their house. And one patient asked me, what do you mean that I have a poor risk disease? Because I never explained her, and she read in my notes that when I put at the beginning poor risk. So I don't know. I think I use it when patients, for example, are on surveillance, favorable risk patients that are on surveillance, then I explain them why they are on surveillance.
I couldn't agree with you more, and you're hitting on something. I like using the term favorable in my conversation with patients. I hate using that term poor, and I find it to be really discouraging. Right. When I'm trying to sort of outline potential outcomes and so forth. So then, reflecting on the scenario here, Pedro, I'm going to ask you a question, and this is, sure. We've already talked about the various indications for the TKI IO regimens and IO plus IO, but let's say you have a patient who walks in and says to you, I really want to get nivolumab and ipilimumab, in a scenario like this. How does that conversation look? I mean, some patients do come in with that perception of just wanting to get immunotherapy alone, right?
Right. So as Christina pointed out, right, we did develop a 214, Ipi/Nivo trial, focusing on intermediate and poor risk. But to be honest, my question to you, Monty, was, am I treating this patient in 2017 or 2023? Because I actually would offer Ipi/Nivo to this patient, right? Now, as you know, it's a question mark whether or not we would do it today in the favorable risk, just based on the trial, if you will. Do I think it would be appropriate to offer Ipi/Nivo to this patient? Oh, absolutely yes. Right, so I think that's appropriate. So now the thing is, when you look at the endpoints, it's a composite endpoint, if you will. You're looking for intermediate and poor risk, and then when you look at good risk, we know these patients do well no matter what we do, right? And I think that's one important message. And so we're coming out of this meeting, and we see these, updated follow-ups for all the trials, right? I think it's really relevant. Now we're at 6 years with Ipi/Nivo, 5 years with Axi/Pembro, and so forth, and the others to follow just by, when we develop those studies. I think actually we need longer follow-up for the good risk. Because if you look at the medians, right, you really need to see what's going on beyond year 4, year 5, year 6, right? And so, my conversation with them always or still includes an IO-based approach. For the most part, right? It's not this patient, but if I have a patient where I do believe that survival is not impacted by kidney cancer, that's the only cases where, or the disease is moving, because if the disease is not moving, I even think about active surveillance. It's not this situation, but I'm just, telling you how I walk through this case. But, in some cases where I do believe survival is not impacted by kidney cancer, that's what I'm thinking a TKI monotherapy might play a role. That is the minority of the times. Okay. In most of the times, even though you have a more dominant of an angiogenic signature, we do know that actually the responses, including CR rates with an IO-based approach like Ipi/Nivo in the good risk, are actually quite good. Double digits for CR rate, for example, etc. So I'm not shocked at all that some of us actually do Ipi/Nivo including the good risk. I just, by virtue of how the trial was designed, and I actually think that IO TKI do perform very well as well. But that's actually one of the areas where after I do IMDC, I spend perhaps a little bit more time, because I have to go through all the options, and I would argue that there's a number of valid options for that case.
Okay, so you're suggesting we could do Nivo-Ipi, or we could do a TKI? Or we could do TKI and
So
IO.
for this particular, you asked me in general. You're right.
In general, favorable risk.
In
what would you
general,
do?
that's how I walk
Yeah.
through. Now I select a little bit of the, or
Yeah.
let me rephrase that. I phrase the conversation what I'm more likely to consider, right? So if you ask me the question for this case, right, in front of us, right, this patient had badass cancer to begin with, right? Like you look at that tumor, that looks ugly, right? So to me, even though the recurrence happened 2 years later, I don't think this would be a patient I would watch, for example. I don't think I would offer TKI monotherapy in this patient who recur with liver mets, but with lung mets, excuse me. So I would definitely consider our IO or an IO TKI. I feel very comfortable with IO TKI in this setting. That's kind of what I'm tending to do more recently. Yeah. But if someone comes and say, I'm going to do Ipi-Nivo and then save it for later, I wouldn't be shocked.
I think TKI-IO is kind of the way that I'm steering, and it's hard for me not to sort of think about this biologically, and you sort of alluded to this. I think you're absolutely right. And I think about when, sort of Tony and Danny were coming up with the IMDC algorithm for us, right? And it really did select out those patients that benefited from VEGF-directed therapies, maybe more of an angiogenic population. So for those reasons, I think ultimately we're probably on the same page. I'm leaning primarily towards VEGF-IO. I mean, Tony, what are your thoughts?
I mean, there is nothing left for me or anyone to say after Pedro's, he went over RCC in general.
Yeah.
First, do I discuss IMDC risk factor in patient? No. But what we discuss is patients, if they have some factors at baseline when they see us that could impact the prognosis more than anything else. So you have to use language that is extremely, at least in tune with patient. And I think with Casey Cure and Dina, we understand how much the language is so important for patients. Because imagine if you start seeing patients say, "Oh, you're poor risk." What does that mean? Should I just sign my? That's not how this is great for papers, but it stops there. I think in this patient with favorable risk, if they're not surgical candidate, let me repeat, those 3 enlarging lung nodule 2 years later could be in the right lower lobe, for example. If they're not surgical candidate, they would need systemic therapy, assuming this is clear cell RCC. And while IO, meaning Nivo-Ipi, is not wrong here, because now after 5 years follow-up, we know that the hazard ratio for OS in favorable risk is less than 1, is 0.94. So you're not hurting, and you lose on PFS, you lose on PR, partial responses, you gain on CR, 12% versus 3% or 2%. But as a reminder, TKI-IO, especially with Cabo-Nivo and Pembrolizumab in the favorable, the CR rate, are north even of 10% higher. And based on the response rate and the PFS benefit, I bought that as my paradigm in the favorable risk, and I do VEGF-IO over IO, unless I have really a reason not to use a VEGF-IO or a patient that motivated, very young, I can give, one shot. Here, I would use VEGF-IO.
So we're going to speed things up a little bit here, and I'm going to change up the clinical scenario. So let's assume this patient actually presented with de novo metastatic disease, meaning at the time that you noticed their primary kidney lesion, you saw that they had multiple lung metastases. Let's say this particular patient had bone metastases as well, and this relates to several of the questions that we're getting in the submitter today. In a patient like that, Christina, I'll throw this one at you. Let's say the patient doesn't necessarily have symptoms from the primary tumor, no pain, no bleeding or anything of that sort. How are you thinking through cytoreductive nephrectomy? Are you offering it to everybody? Is it something you consider sort of only on an as-needed basis for urgent cases?
I think it's a very interesting question, because before the Carmina trial, we were performing nephrectomy to everybody. Now we are not performing nephrectomy anybody. So I think if there are no symptoms, we should start with systemic therapy. But what we are realizing now is that it's very difficult to achieve a complete response if you have the primary tumor there. So I think we should start reconsidering, reevaluating the patients, and maybe if they are, because I have many patients like with these new combinations, and especially in trials, that they have a complete response in the meds, but they still have like 8 centimeters of in the primary tumor. So And we know that complete responses are directly, it has a directly relationship with the outcomes, with the overall response rate and PFS. So maybe I think we should start considering delayed nephrectomies in these patients, at least in patients with good responses.
I tend to agree with you. What do you think, Pedro?
Well, that's perfect segue to the trial that I was about to highlight. I love that approach. You offer an induction of systemic therapy up front, and you select the good actors from the bad actors. In other words, it's the patients where you will know likely they're going to benefit. So you basically highlight an important concept that I believe, that we do see, that the response in the primary tumor tends to be 20 to 30% less than what happens elsewhere, right? And so you got to deal with something. So when you start someone with systemic therapy, whatever IO-based approach you consider, and you recheck after 3 or 4 months, right? And the patient is doing great, good response, you got control of the disease, you really want to take that out. Yeah. There's actually a trial doing that. At least we're part of PROBE, that's literally asking that question. And I really think it makes a lot of sense. And to be quite honest, we have participated in that trial. There's a big effort from the cooperative. A lot of our colleagues are doing it. And to be quite fair, I cannot think of a patient that not benefited from that strategy. So I really think as we move forward, thinking about systemic therapy first as a way to control the disease, and then coming later on and address the primary tumor makes a lot of sense. And I do believe we're helping people.
I think that makes a lot of sense. Now, I want to go, I told you we're going to get progressively harder with these cases, right? I want to go to a scenario that we haven't talked about yet, but was brought up earlier. So let's take the same scenario that you see up here on the screen, okay? So the patient, had a resection, but then subsequently had received adjuvant pembrolizumab, okay? I'm going to play through a couple of scenarios for you, okay? Let's say this patient had, again, localized clear cell disease, T3, right? Okay. You put them on adjuvant pembrolizumab, which is what we said we might do when we were discussing this patient earlier. And let's say they actually progress with new lung nodules while they're on adjuvant pembrolizumab. Let's say this happens about 9 months into therapy. And we're starting to see that, right? I mean, it's happening in our clinics. So, Tony, what are you doing in scenarios like that? Are you giving TKI monotherapy? Are you giving combo therapy? What's your approach?
I think progression while on, and we should say tumor progression, not patients progressing. Tumor progression while on adjuvant or while on therapy, to me that equal progression on like metastatic disease. And I think here it will be very hard to justify re-challenging with an IO. However, I would argue that's atezolizumab, it's a PD-L1 inhibitor, etc. We're seeing a practice all over the place. We're seeing people, physicians and providers switching to single agent TKI. I've seen sunitinib, pazopanib, I've seen a lot of cabozantinib. I've seen folks challenging with nivo-ipi. And we know that at least based on fraction RCC, there's a response rate of 17%, certainly way less than nivo-ipi untreated patient. Right. And I've seen folks continuing pembro and adding axitinib or lenvatinib.
So because we're short on time, you tell me what you do. What do you do in clinic for a patient like this?
I switch to single agent TKI.
Christina, short answer here, what do you do?
If I could.
If you could.
If I could. Maybe if it's in this short time and after the CONTACT-03 results, I would choose TKI monotherapy.
Pedro, do you have consensus there? TKI monotherapy. So we've got consensus there. So let's make this a little tougher and then we're going to move on. But let's say this patient, I think it's pretty obvious what we do if the recurrence happens 3-4 years later, right? I mean, that's like a patient who's got a newly evolved disease state, right? You can re-challenge with IO. Let's say this happens 1.5 years out, right? That's what I really struggle with, right? So they finish their adjuvant therapy, and then 6 months later, right, when you expect that immune therapy to still be working, right? Then they progress at that time frame. What would you do then? We'll start in the other way. Pedro, short answer.
Yeah, I probably would go an IO TKI in that case, probably.
Okay, 6 months?
Yeah, it will probably. The SIG task force decide, or they established 12 weeks to consider a patient resistant to IO or not, which I think it's too short. But maybe 6 months, I would consider an IO TKI. I don't know.
Okay, and Tony,
I would do TKI only.
I don't know.
My limit is 1 year. After 1 year, I re-challenge with IO. I could be wrong. The only difference is nivo-ipi based on the phase 2. It wouldn't be wrong to use nivo-ipi based on the phase 2 fraction RCC.
Excellent. And I just want to point out we have a star in the room. Dr. Ibrahimi is one of my fellows who's going to be discussing what I think is, potentially a novel avenue in kidney cancer therapy. We're going to be looking at Cabo-Nivo with this live bacterial product called CBM-588 in a special clinical science symposium on Sunday. So I encourage you all to come to her talk then. It should be some interesting science. And I'm going to transition it over to Boss Man. Tony, you don't need an introduction, do you? He taught me everything I know about kidney cancer, honestly. Professor and the head of the Link Center for Genitourinary Oncology at Harvard. Just a tremendous force in the field and a wonderful mentor. Tony?
Oh, very, very kind of you, Monty. So thank you. What about the refractory setting? So we went with early stage systemic, with adjuvant, neoadjuvant, first line untreated patient, metastatic, now metastatic refractory setting. And that's the disease algorithm depending on what did you get before and what country you live in, sadly. So if you receive VEGF TKI monotherapy, we still see it even in the US, usually nivolumab or cabozantinib based on an OS benefit from the 2 phase 3 trial. IO combination, we've seen mostly in terms of paradigm VEGF monotherapy, and this is illustrated in a consensus led by Dr. Kim Ratmel from Vanderbilt. If you get VEGF immunotherapy combination, usually it's the VEGF TKI you did not get. Also, we see practices all over. And if you get oligoprogression on immunotherapy, and I would say even on TKI for whatever reason, you get local therapy. And that makes sense, and makes sense in many solid tumor, actually, whether radiation, ablation, excision. We have it at our place, we have everything. But, in other places, you do have surgery sometimes. You don't have those options. What about other drugs here are part of the therapies, the arsenal that we use in refractory population? Want to give your attention here to tivozanib. Important to remember the study. Maybe it didn't get a lot. This study you've been involved with, Monty, Brian, Dave McDermott, and others. This is a patient population whose tumor progressed on 2 or more systemic therapy, including, most important, VEGF TKI. This was a study where all the studies before were against everolimus in that setting of monotherapy or combination. Here, it is with sorafenib, it's VEGF TKI, 350 patients, so smaller if you want randomized phase 3 trial, randomized 1-to-1. And you can see the benefit in terms of progression-free survival that favored tivozanib versus sorafenib. And you can see also the tail of the curve with a proportion of patients that is, I would argue, clinically relevant, that are progression-free after 3 and 4 years, with activity across all subgroups that were tested. Tivozanib is it's a clean VEGF TKI. Not surprisingly, the side effects are especially hypertension, fatigue, but especially, hypertension here. And overall, it has been better tolerated. If you look at the subgroup of patients, this is more recent trial that get prior immune checkpoint inhibitor, the effect is even slightly, better. Now, if you make it to 12 months, and there are biases when we look at such curves, when we assume you made it to a year, and we look at survival after that, now things get even better here. Patient on tivozanib continue tivozanib and do well. Now, one thing with tivozanib initially get a bad rep out of a study that pinned it against sorafenib, but in untreated population because of the hazard ratio for overall survival. And I'm not gonna, go through this. There was issues with crossover in one arm versus the other. But if you look at different cutoff here with TiVo3 in refractory patient, the hazard ratio for overall survival has been always less than 1, and even maturing now less than 0.9. So a consistent response rate, consistent PFS, that's the primary endpoint with tivozanib over sorafenib, with potentially improving OS. At this point, it's not significant. Tivozanib have been also combined with immune checkpoint inhibitor, here with nivolumab in untreated patient, a median PFS around 19 months. I would say this is a very good PFS compared to what we have. Patients were either treated or previously untreated. And based on the safety from that combination, we launched a study actually that close to accrual yesterday. TiNivo2 is a very important phase 3 trial. I would say it's the PD-1 version of CONTACT-3, where patients whose tumor progress after immune checkpoint inhibitor get tivozanib or tivozanib plus a PD-1 inhibitor, here nivolumab. So with CONTACT-3, it's the TKI plus a PD-L1 inhibitor. We heard the press release from CONTACT-3, it's negative. But here with a PD-1 inhibitor study, finish accrual. Other combination approach with lenvatinib here and pembrolizumab. Again, the interesting thing here in patients that are treatment naive, that's great. We have data from CLEAR. But in ICI pre-treated, 104 patients, 55% response rate. Now, is this pembrolen or this len alone? Certainly not pembro alone. That remains to be seen. I would say, we don't know at this point. This is a combination that Dr. Pal led, combining atezolizumab with cabozantinib, and based on this, we launched CONTACT-3 study that both Monty and I led. Excellent responses in clear cell RCC patients that were previously untreated. And you may say, wait a second here, so why did you go to previously treated patient? I think because, be honest with you, what do you do? How do you launch a first line trial, let's say with a VEGF IO? What will your control arm be? You cannot do single agent TKI. The unmet medical need is in patient post checkpoint inhibitors here. Now, there are strategies here that I do want you to understand they're coming, especially if the trials are positive. HIF2 inhibition. HIF2 is a transcription factor. It's not on the cell surface, very hard to target, but elegant work showed that it can be targeted with a molecule here that went through letters and numbers to more letters and numbers, and now to a full name, belzutifan. That molecule was used in VHL syndrome, a disease that is characterized by alteration in germline VHL, in germline alteration in the VHL gene, and renal cell cancer as well as other lesion, and showed the response rate really in the north of 50%. But here in clear cell renal cell cancer, we led LightSpark 001 that showed a response rate of 25%. Those are patients, with 3 prior line of therapy, with a total monotherapy in totally new class of agent, a median PFS of 14 months. Kind of interesting waterfall plot. You see waterfall plot or just, everything up, fountains, nothing in between. This is different than a VEGF TKI. We don't have a biomarker, but remember the name belzutifan. Not approved in renal cell, in sporadic renal cell carcinoma, but we do have a trial, I wouldn't say underway, finished accrual some time ago, and hopefully over 700 patients versus everolimus in heavily pretreated patient, post PD-1, post VEGF. And if this trial is positive, you have 2 primary endpoint, PFS and OS, then you may have a new drug here to offer to patient. And we have combined this drug, belzutifan, with a TKI, cabozantinib. We found that it's combinable. There are responses. This is in patient, that also heavily pretreated. 87% had a reduction in target lesion size. And based on that, another study with a different TKI, lenvatinib, and belzutifan, in patient as second-line treatment was launched against cabozantinib, and that trial is actually enrolling. So this could be the future if something is positive here. Now, update, a study at belzutifan plus lenvatinib. So this is the TKI. This is based on the phase 3 study. So belzutifan 120 plus lenvatinib 20 milligram, response rate of 50%. Those are in patients that heavily pre-treated before, and that justified, of course, especially with a median PFS of 11 months, small number of patients, but justifies the phase 3, because everyone was saying, well, you have data, but it's with cabozantinib. You can't just do this interchange between TKI when you want and when it suits you. And at the same time, all these studies, we learned it the hard way, are collecting tissue, are collecting blood to test in real time or maybe just after a year or two signature. With Dr. Salibi, for example, in the audience here, we are looking at specific signature that on the with phase 3 trial with VEGF-IO, can test, as well as cytokine, your work, cytokine biomarkers, can test a specific biomarker that has been discovered before, like with Emotion 150 and 151 in novel combinations. So stay tuned. The paper will be ready even during ASCO, right? Okay. What about CAR T? I think Monty was one of the first people to push this, and this is, ongoing strong, but slowly. I would say slowly. I think here the kudos not just to you, Monty, and the City of Hope, but the hematology team at the City of Hope. CAR T in solid tumor or even in liquid malignancies really is very hard. I don't call it CAR T, I call it CAR team, T for team, not just T cell. It's a huge team of folks. So here, a compound, want to highlight, ALLO-316, want to highlight because this, I believe, was just presented at the AACR not long time ago, a couple of weeks ago. So this is an allogeneic off-the-shelf anti-CD70. CD70 is prevalent. That's the target on RCC, a CAR T. And here it was used without any major unexpected safety signals here. I don't want to go through the structure. What did they knock down? What they're giving? How they're prepping? But usually this is minor difference, among all those CAR Ts. But the CAR T folks says there are major differences. To us, there are differences, but here, just to show you those 18 patients, interesting. This is interesting because one infusion, and either you have a response, you have activity or not. You don't have a combination with another potentially active agent that can muddy the water. So interesting enough, in all patients, the response rate 17%. I mean, 3 out of 18. I would say no CRs, I believe. That's not bad, a good disease control rate. But when you look at those patients that are CD70 positive, now the majority of patients, 10 out of 18 are CD70 positive, but not completely everyone. Suddenly, the response rate is 3 out of 10. I think this is very interesting. So the work goes, but just to let you know, every time there's a new version of CAR Ts. But these are here to stay. One of the big problem we have when we get, patient referral for CAR T or other, CAR-based cellular therapy is the patient have to be really fit, really committed. The slots are not always easy, and the technologies are changing very fast. But that's something to look at. Again, I think we're all extremely delighted, but also humbled by the work that Casey Cure and Dina and all the friends and fans of Casey Cure do here. This is a survey of over 1,000 patients. 1,000 patients with renal cell cancer. Almost 400, had metastatic disease. And what Dina and her team here wanted to show is that what are the patient priorities and expectation for systemic therapy? Let's say in patients that are battling kidney cancer, not the first round, but the second and the third round. So you ask them question, and what are the expectations from the patient? This is the patient voice, and remember, this is beautiful. Why? This is not in the presence of physician, hopefully not in the presence of other family members, etc. This is the patient and themselves. So what the patient, come with, and I'm not surprised here sometimes, but it's good to have evidence. Most patients are not familiar with their classification, okay? Although it's important to know that, even if you don't understand it, but I think for prognostication, this is important. Now, patient, you may think they rank partial response, they rank the time of therapy. No, they rank complete response at the most important desired outcome for that when they considering treatment. Most of them, not all of them. You can see here the beautiful color in green and orange, and I would say green is the color of kidney cancer, although orange, take over from time to time. And the patient perception for long-term response are different than their provider, than their doctors and the nurses. So this is very, very important to see how patients interact with the information, and they may be getting information not just from their provider, and that's important. That's what we're here for, and the information outside the doctors and the provider are more and more to come. Not just the internet, that come from multiple ways. Sometimes they're not looking, it come to you. If you Google something, suddenly you have a treatment in your face. I know we shop for something, and then suddenly your page shows up. What we tried also to do is that what are the important trials here in progress that you can see at ASCO 23 to highlight it for you. I think these are important to see how things are going. One important trial is combining the HIF2 inhibitor we talked about with palbociclib. That's a drug we use in breast cancer. It's a CDK4/6 inhibitor. There is very elegant work, all preclinical and animal models from Dr. Bill Kaelin, my colleague, my friend, who's the Nobel 2019 Nobel Prize winner, based on his work in kidney cancer and oxygen sensing, that HIF2 inhibitor and CDK4/6 inhibitor should be and could be combined. So immediately this went to a trial that Dr. McDermott here is leading. I believe this trial is accruing. Will be very, very exciting to see the results soon. Also, this is another study here that we changed a bit, 092. This is a new TKI in combination with nivolumab, with ipilimumab, the IL-2, although we're changing that, but at least to know that there are some what we call combination studies are ongoing, where you take in and out some of the drugs and you continue with the backbone. Dr. McKay, one of my former postdoc, she moved from Boston to California because of you. But UCSD, not at City of Hope, she's co-leading a randomized phase 2 study where she's interrogating radiation in the form of SABR, stereotactic ablative radiation therapy. We say always that radiation, doesn't work in renal cell cancer, where yes and no, if you can go high on the dose in untreated patients. That's the Samurai trial. And finally, there is a nice study here with cabozantinib and nivolumab and lutetium girentuximab here in patient with advanced RC from Dr. Hassanov, who moved from MD Anderson to WashU, I believe, recently. So, the field is actually in renal cell cancer full of hope, in my opinion. Monty, I think back to you, right?
Yeah, that was terrific, Tony. Thanks a lot, my friend. Appreciate it. Just an editorial comment. It's hard not to look at those slides and actually get a little bit nostalgic, because I saw your slide on, CD70 targeting CAR T cells and so forth, and I just think about when I got my start in the field. It was actually thanks to Tony working on a compound called XL184, and this was 17 years ago. Oh my
gosh, yes.
Tony was so generous, pulled me into the phase 1 clinical trial, and I have two messages. One is that if you're an investigator sitting in the room, it's just so critical, that you have somebody who sort of takes you along for the ride, the way that Tony's done for me, the way that we'd like to do for Chris and Pedro sitting here. The other message is that I think there's a lot of hope, right? You think about, this next wave of therapies that we're generating, entirely different mechanisms of action, whether it's HIF2 inhibitors or CD70-directed therapies. It's a very, very exciting time in kidney cancer. I think we're getting away from just looking at PD-1 and VEGF now, although those have been monumental improvements. I think that this is just going to be an exciting decade or two for kidney cancer.
Absolutely, therapy. And when you're old, when a drug that had no name, becomes, has a name, then there's a second generation of the same drug that has a new name, and you're like, you're in this field for a long time now.
Yeah, absolutely. So we're going to reflect on this scenario. So we ultimately treated Maria, we're going to imagine in this scenario, with an IO and TKI regimen. And this patient ultimately progressed with new and enlarging lung nodules and additional liver nodules. She has some concerns around quality of life and toxicity of therapy. You can imagine whatever regimen you'd like in the frontline scenario, but just in the interest of time, let's do this. Just go ahead and sort of tell me what your preference would be in the frontline setting for a patient like this, and given that preference, what would you necessarily use as sort of the second line therapy? So I'll start. I typically begin patients in a scenario like this on cabo-nivo. This patient's concerned about quality of life. I think that the data that Tony and others have presented really suggests that that's a regimen amongst the TKI IO regimens that seems to stand out. Second line setting, maybe this is a little bit controversial, but I actually tend to use tivozanib in that second line setting. If the patient is frail, and many patients can be, I think it's a very well tolerated option. That tends to be sort of my mainstay. If the patient really needs aggressive therapy, I might use lenvatinib, everolimus, but I find that to be a more challenging regimen to tolerate for most of my patients. So that's my approach. So again, what TKI IO regimen would you typically start with? Again, let's leave nivo-ipi out of the equation right now. And then what would your second line choice be? Let's work down the aisle here. We'll start with you, Pedro.
Yeah, no, I think your options, I was thinking the same. I was debating what would I do. TiVo is an option. Axi would be another option. I tend not to do everolimus right after IO because I don't have a lot of data on that. Nothing against lenvatinib, right? But it's perhaps a little bit more toxic. She's concerned about quality of life. You'd run a beautiful study, showing a lower dose. So for all those reasons, I think, between TiVo and Axi probably would be my choice.
Got it. Christina, what about you?
So the TKI that demonstrated better benefit was cabozantinib in some retrospective trial, and a trial is going to be presented tomorrow when it's compared with other TKIs. But as you mentioned, if you use nivo, cabo in the first line, maybe TiVo would be a good option based on the TiVo-3 trial or a clinical trial.
Fair enough.
But that would be my choice.
Yeah, fair enough. Tony, what about you?
I would use the TKI that hasn't been used, a single agent here. So if you haven't started by cabo-nivo, then cabo becomes later. Let's say you started by pembro-based regimen, then definitely cabozantinib. You're gonna see some data of monotherapy, the largest in a randomized from CONTACT-3. I think tivozanib is very reasonable also. And I have seen some folks using nivolumab, ipilimumab, but the response rate, is 17%, some durable responses, but in some situation, but certainly it wouldn't be coming from a phase 3 standard.
So let's talk for a moment about belzutifan. We all know the indications for it. We didn't really discuss it at length, during our talk today, but for patients with germline VHL alterations and RCC, very reasonable option in that context. But I'm starting to see this trickle of patients in the community who are gaining access to belzutifan right now for somatic altered VHL, for instance, and so forth. And I just wanted to kind of get a perspective from you guys on that. And Tony, you've done a lot of work with belzutifan to date. What are your thoughts on that practice? And let's imagine a scenario where you could potentially access it through compassionate use, et cetera, ahead of the phase 3 trial that you're leading. Well, when would you use it?
I mean, in later lines, we had some luck overall, at least I would say 50%, putting the paper and appealing again. We were in the car discussing Pedro, got approval after 3 appeals. Takes a lot of time on us. That's how we spend part of our time. But later line, but the data come from 25 patients. We feel comfortable, I think some of us, because we've used it as part of clinical trials. So we know the drug very well. So I feel comfortable on that. But I get it. Patient that can get on trial wants something with a tolerable and, want to fight this. We're able to get it for some.
But I think your point's well taken there. It sort of comes after sort of the tried and true tested regimens that we have, right?
Mm-hmm.
Based on available data. So, I think that's a good message to kind of close on. And one of the themes that I've noticed is that we've all sort of, I think, come around to really support regimens that really do, have good evidence to back them up. by and large, and I think that's a good takeaway from the evening. So with that in mind, we've gone through a lot of the questions that the audience tonight has actually submitted through the portal, and I hope most of you have gotten your questions answered through the course of the evening tonight. I do want to thank my outstanding panel here, Tony, Chris, Pedro. You guys have been amazing, and really a wonderful audience here tonight as well. Thank you for coming out, and enjoy your ASCO.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/DGX860. This educational activity is supported by medical education grants from Aveo Pharmaceuticals Incorporated, Eisai Incorporated, Exelixis Incorporated, and Merck & Company Incorporated.